educating you guys about treatment modalities for depression. I really hope to kind of spread the word about TMS so you guys will refer more patients to our clinic for general evaluation and possibly TMS treatment down the road. With that being said, I do not have any financial disclosures. Please do not forget to text in for the elusive CME credit. And let's get started. So what better way to start than with the case? 50-year-old man with treatment-resistant depression has exhibited only minimal responses to a couple antidepressants, including fluoxetine Prozac, escitalopram Lexapro, and venlafaxine Effexor in his current depression episode. He has a history of pretty poor tolerability to ECT or electroconvulsive therapy treatment in the past, and he's not interested when you ask him about getting the treatment again this time around. So what do you do? In the end of the presentation, we're going to come back to this, at which point, hopefully you'll understand a little bit more about why I gave the case the way I did, understand the underpinnings of what I'm asking for, and be able to think of maybe at least one option going forward. All right. Here's the whirlwind tour we'll be embarking on this talk. I'll touch a little bit on the diagnosis of major depression, but I actually really just want to focus on treatment-resistant depression, different modalities for depression, and then run through what in the world TMS is. And if I have time, I'll show you guys also a reference slide on other neuromodulation therapies that are of pseudo interest right now. This will admittedly be more catered to those of you guys who are practicing the general outpatient setting. Honestly, though, if I covered inpatient settings, different population subsets, or got into the weeds or nuances of depression, I would probably be here for at least 5 hours, and no one wants that. So first of all, how do we diagnose major depression? I think most medical students and even faculty will probably think about the mnemonic SIGI CAPS, and you will be right. It is a surprisingly decent way to remember depression symptoms. However, I really want to draw your attention to what I bolded over here. So we do need 5 or more symptoms that I listed below in the same 2-week period. So not a symptom here and a dispersed symptom in a different time frame entirely. And also a core change in mood of either a depressed mood or a fancy term we call anhedonia, which really just stands for a loss of interest or pleasure in the things you normally like to do and enjoy doing. So for example, right, you're working on the unit for 6 days, 7 days straight, you're really stressed out. You might be eating less than usual because you're really stressed out and tired. You may be eating more because that's how you compensate. You're not sleeping well, you're feeling tired, fatigued, you're moving slowly, or maybe you're moving faster if you're chugging 5 cups of coffee and you're not concentrating as well. That's, if you count that out, that's actually 5 symptoms, but that's not a major depression episode. You really must have this fundamentally core change in your mood or loss of interest in pleasure. The next criteria underneath all of this is something that spans all of our psychiatric diagnoses, which is that these symptoms must cause some sort of impairment in functioning, whether it's at work, socially, or at home, or with friends. The last, let me go backwards. The last 3 bullet points right over here essentially refer to the fact that, you've ruled out other causes of seemingly low mood or symptoms that overlap with major depression. So for instance, substances. The classic example would be like a stimulant withdrawal syndrome, or maybe a sedative hypnotic intoxication syndrome that might look like low mood, fatigue, and a lot of depression-like symptoms. Another example would be general medical conditions. That's something that you might see on our notes or diagnoses as depressive disorder due to another medical condition. The common ones that you think about are hypothyroidism, Cushing syndrome, Parkinson's disease, amongst many others. And finally, we want to rule out any psychotic disorders and any kind of bipolar disorder. All right, so what do you do first? First of all, the initial psychopharm approach, the ones that people are most familiar with probably are SSRIs and SNRIs. I'm not going to go into nitty-gritty details about those because they are, again, common to a lot of people. I will list kind of just a couple ones, though, that you will see a lot being prescribed in the outpatient setting by both us and also by primary care physicians. So fluoxetine Prozac, sertraline Zoloft, and escitalopram Lexapro are probably the most 3 commonly prescribed SSRIs currently. As for SNRI, so serotonin and norepinephrine reuptake inhibitor, we have venlafaxine Effexor, desvenlafaxine Pristiq, and also duloxetine Cymbalta. These are also prescribed a lot by neurologists for neuropathic pain and for migraines. The 2 that I want to highlight here now are actually mirtazapine and bupropion, these 2 over here, because they're not as commonly well known. However, they are still considered really good first-line agents for major depression. So mirtazapine Remeron is actually a presynaptic alpha-2 blocker, which all you need to know from that is that it eventually increases norepinephrine and serotonin really far downstream. However, it doesn't do the same thing as SNRIs do. So it doesn't work on the reuptake transporters, and it's free of a lot of the side effect burden that SNRIs actually have because of its different mechanism of action. It also touches a little bit on histamine 1 receptor at lower dosages. So in other words, it causes sedation. The prototypical, patient who will benefit a lot with mirtazapine or Remeron will be somebody who's suffering from depression and also dealing with insomnia and maybe having low appetite, because mirtazapine does boost appetite. The last one here, bupropion, is going to sound familiar probably to a lot of you out there because you may have prescribed it, probably maybe not for depression, but for smoking cessation. The sustained release of this medication is actually branded as something called Zyban, Z-Y-B-A-N, and it is approved for smoking cessation alongside Chantix and nicotine replacement therapies. The one thing I want to note about bupropion is that it has some unique contraindications that other antidepressants don't really have. It does have a slightly increased risk of seizure. So the contraindication here is anybody with active seizure disorder. This includes anybody who is at risk for alcohol or benzo discontinuation. And of course, related to that, active eating disorder, so anorexia nervosa or bulimia. So let's say you tried the first antidepressant, you tried a classic SSRI and it doesn't work. What do you do next? Well, you wait, right? We say 4 to 6 weeks. There are a lot of nuances to this. So if you want to hear the soapbox version, just contact me offline at some point. But 4 to 6 weeks is a good heuristic to kind of use for now. So you try that out. You really should wait it out before you try to keep bumping up the dose, because you really want to assess for the maximum benefits at the current dose that you're already on. What do you do after that? You could try switching actually agents. So an easy switch, for instance, would be if you try SSRI, you can switch over to a different SSRI. You can switch to a SNRI. You can switch to the Remeron, mirtazapine, or also bupropion, Wellbutrin that I mentioned on the last slide. You can also refer the patient for psychotherapy here, assuming that we're talking about the clinic here. Psychotherapy is indicated at pretty much all severity levels of depression symptoms. So you don't have to wait until a patient is severe enough, if you will, to refer them to psychotherapy. It works with or without medications. And for milder cases of depression, people actually recommend that you refer patients to psychotherapy immediately first. You can also consult us. If you tried 2 antidepressants, right, that you're feeling really adventurous, you tried 2 different ones and they didn't work, please refer over to us. If symptoms start worsening, refer over. If there are any safety concerns at any time, and really any time that you feel uncomfortable, please feel free to consult over to psychiatry. So let's just say the patient fails the first medication trial and even the second medication trial that you tried. Just understand that that's not the rule. That's really the rule and not the exception. And there's nothing that you or the patient is doing wrong. In fact, this was shown in the STAR-B trial, which is this NIMH-funded, huge, multi-centered, randomized trial with 3,000 some patients, which looked at remission rates with different antidepressant treatments when using a multi-tier protocol. It's still the largest and most consequential antidepressant study to date. What it found was that really only 1 in 3 patients actually achieved remission after trying 1 antidepressant. And majority of patients actually require multiple antidepressant trials before symptoms remit entirely. This graph here really just shows remission rates at the 4 successive treatment steps in this study. You'll see here that the first step of note is treatment with the primary SSRI, Celexa, in this case, citalopram is a generic name. You'll see remission rates of about kind of 30% or so for the first 2 steps, and it rapidly drops off at individuals requiring the 3rd or 4th treatment steps. And these other treatment steps could be a mix of either switching from one antidepressant to another or augmentation. In other words, adding a different medication on to boost the benefits, which we'll talk a little bit about in a later slide. So in other words, 1/3 of patients with depression remit with a single antidepressant, and the likelihood of remission diminishes after each unsuccessful antidepressant treatment trial. The STAR-D study's findings earlier really kind of pushed this conceptualization, if you will, of TRD or treatment-resistant depression. Unfortunately, there's really no clear-cut consensus on the definition of TRD. However, the Agency for Healthcare Research and Quality, which is just a major department under HHS, performed a really comprehensive review back in 2018 of relevant literature and published studies on TRD. And they found that the most commonly reported definition required a failure of at least 2 antidepressants of adequate dose and duration. It gets a little bit complicated though, because experts diverge on many of the nitty-gritty details, such as whether the 2 medications can be in the same class. So are 2 SSRIs, does that count? Or do they have to be from different classes, like 1 SSRI, 1 SNRI, or 1 SSRI and bupropion, right? They also diverge on what an adequate dose or duration even means. Are we talking about the minimum effective therapeutic dose or the maximum tolerated dose? And are we talking about 4 weeks or 6 weeks? In fact, most studies actually didn't even present the information regarding exact treatment length. So you can probably get an idea of how confusing it gets here in the TRD research world as a result of the lack of formal consensus. So now let's say you have a patient who's failed 2 different antidepressants for 4 to 6 weeks each at a decent dose with their psychiatrist, or maybe even with you. You come to the conclusion that, okay, this is treatment-resistant depression or TRD. What might we do then if you refer them over to our psychiatry clinic? I'm going to actually start with the VA's guidelines because they specifically address TRD and also because they're more updated. So they specifically say for patients with depression who've had 2 adequate pharmacological medication trials, let's just put it like that. They recommend trying monoamine oxidase inhibitors, aka MAOIs, as well as tricyclic antidepressants, aka TCAs. These are some of our older, if you will, antidepressant types of medication classes. However, they're still effective, and some experts feel like they might be more effective than some of the antidepressants that we have currently. The only issue is that they're bogged down by a lot of side effect profiles, difficulties with adherence because there's a lot of medication interactions, and plus sometimes dietary restrictions. So they're not our first line go-to as a result. Unfortunately, the American Psychiatric Association, the APA's guidelines, are a little bit more unclear, and they're also dated. If you look at the year, definitely more dated than, for instance, the AHA, ACC's guidelines on hypertension. These are mostly buried under the APA's general management of depression guidelines, and TRD is actually not defined anywhere. However, they do mention these as options to address inadequate response to initial treatment. So the way that they break it down is either switching agents. You can switch to a non-MAOI antidepressant like SSRIs, SNRIs, TCAs. You can also switch over to MAOIs. You can augment the initial antidepressant with another antidepressant that's not an MAOI, and you can also augment with other agents that are not really considered antidepressants, but they do help with depression response when combined with an antidepressant. So for instance, lithium, thyroid hormone, we're talking about T3, by the way, not Synthroid, and second generation antipsychotics. The most 2 commonly prescribed ones that you will see, probably aripiprazole, aka Abilify brand name, or Seroquel, that's the brand name, and quetiapine being the generic. Here is a list of advanced augmentation strategies, not for you guys to memorize or even really to kind of take home with you. It's just so you guys know that this is what we do in our psychiatry clinic. When patients come to us, we tried a lot of other things. These are definitely more advanced medication strategies that we can try to tack on to the antidepressant. This includes anticonvulsants, stimulants, anxiolytics, omega-3 fatty acids, L-methylfolate, and SAMe. The last 2 of note are actually, they kind of work on the same folate metabolism methylation pathway, with the underpinning of that majority of, well, not majority, a good number, I guess I should say, the population have polymorphisms in an enzyme that's crucial in the folate metabolism pathway, and that is associated with more depression symptoms. So these are the newest psychopharm options approved for major depressive disorder in the last decade. Don't be surprised if none of these really sound familiar to you aside from maybe esketamine. It's really to show you that we've been trying out some pretty unconventional approaches to depression in terms of mechanisms. In my opinion, the only medication here that's relatively straightforward is levominosopran here. This is just a fancier SNRI. It's actually an enantiomer of a medication that might be familiar to some of you guys who treat fibromyalgia, milnacipran. You might also notice on here dextromethorphan, which is exactly what you're thinking of. It's the same one in cough syrup. This combination was really just approved late last year and was built off the success of ketamine and esketamine because they're all NMDA receptor antagonists. So really kind of piggyback off the success there. So let's switch a little bit now to non-psychopharm modalities. We talked about psychotherapy. Just want to remind everybody about that again. There's also electroconvulsive therapy, or ECT, which is still considered our gold standard for many, many types of depression kind of subtypes, and also really severe depression that doesn't respond to multiple medication trials. And then finally, TMS, or transcranial magnetic stimulation, is kind of like the new neuromodulation kid on the block, but it's not really new in the sense that it's been studied in basic science for decades. It's just that the translational clinical science research has been completely blossoming in the last 10 years or so. So let's talk about TMS. Here is a pretty accurate depiction of the setup, the machine. This is the magnetic coil I'll talk a little bit about shortly. Here's the treatment arm over here that goes directly to the stimulator. And then finally, this is like a cooling apparatus. The magnetic coils do look different depending on the device that's used. The patient reclines essentially on what looks like a dentist chair, and the coil is lowered onto the scalp near the left forehead. As a very broad overview of TMS, it's essentially this non-invasive neuromodulation treatment that's conducted without any anesthesia. The patient is awake during the whole procedure, which definitely differentiates it from ECT. There's also no alteration of consciousness, nor potential to dissociate, and like with esketamine. The pithy way to explain how TMS works is that it's all Faraday's law. So basically a pulse of electrical current passing through a wire coil right over here generates a magnetic field. And the rate of change, or flux, if you guys remember physics, of this magnetic field determines the induction of a secondary current in a nearby conductor, which happens to be the cortical neurons in this case. If you didn't understand any of that, just remember that a pulse magnetic field passes through the scalp and skull and induces a current in neurons. The magnetic field strength is only about 1 to 2 Tesla, so more like a standard MRI, not like University of Minnesota's 10 Tesla MRI here. In most studies, treatments usually involve using very high frequency pulses to stimulate neurons around the left dorsolateral prefrontal cortex. This is an area, by the way, that's been shown on PET scans to be hypoactive in depression. In addition, we actually also know that damage to the left DLPFC from strokes is associated with greater depression symptoms, hence why we target that location specifically. Each session used to last between 30 minutes, 37 minutes, up to 45 minutes. But now we have theta burst stimulation, which uses bursts of extremely high frequency stimulation and cuts the treatment time down a lot to just 3 minutes. That's the active treatment time. Doesn't count the time that we get patients set up, that I spend time talking to them about what's going on and get them checked out. TMS is covered by insurance for depression for about 30 treatments or so total, albeit with a lot of caveats that we'll talk about later. So with TMS stimulation, cortical neurons are essentially more likely to generate action potentials, which leads to activation of a lot of deep brain structures via these transsynaptic pathways in our brains, and eventually strengthening of synapses through the process that we call long-term potentiation. This is a list of some of the most studied effects of TMS on the brain, from local changes in neurotransmitter concentrations to plasticity and long-term potentiation. I want to draw your attention to the last bullet point right here. Hyperactivity in the subgenual cingulate cortex, which is also known as the anterior cingulate cortex, is associated with major depressive disorder and also anti-correlated or inversely correlated with activity in the DLPFC area I talked about previously. So this association has been found to actually be predictive of the response to TMS and has been the subject of a lot of clinical research and really just general interest recently. I'll show you one of the many notable studies demonstrating this in a second. Just to orient you a bit to anatomy first, though, this is a DLPFC where the TMS coil will stimulate. And here's the anterior cingulate cortex, aka subgenual cingulate cortex. It's kind of like the frontal part of the cingulate cortex and resembles almost like a collar surrounding the corpus callosum, if you will. In reality, though, the DLPFC communicates with tons of neural networks in the brain, which allows for what is essentially a local cortical excitation to affect even very remote areas in the brain that are involved in depression, with some of these areas and networks kind of mentioned here on this slide. Here's a study that I alluded to earlier. This was a 2019 paper published in JAMA Network Open. It's a lot to look at heads on, but let me run you through it slowly. So orientation-wise, right? Dorsal, ventral, rostral, caudal. Keep in mind that the brain here is actually the mirror image of the one on the last slide in case anyone gets confused. I've had people ask me why the cingulate looks like it moved in the brain. That's why. All right, the study first looked at baseline subgenual singular activity of patients with MDD compared with healthy controls. This was done with EEG readings, which of course is a non-invasive technique used to assess neuronal activity connectivity. In major depressive disorder patients, subgenual singular activity was then compared after active TMS versus sham TMS. This scale right over here is actually what we call significant current density in these kind of readings. Yellow basically means low activity. Red over here means high activity. So at baseline, you can see that hyperactivity of subgenual singular cortex is pretty evident in patients with MDD and significantly higher compared with healthy controls. Now let's take a look at what happens after TMS treatment. You can see on the bottom right here that the subgenual singular hyperactivity was attenuated, in other words, improved or decreased, much closer to the levels of the healthy controls, whereas with sham TMS, the hyperactivity remains exactly the same. So it's pretty outstanding to be able to kind of see this visually as well. As for TMS indications, the one that we talk about a lot is obviously for major depressive disorder. It was approved back in 2008. The FDA approval was technically for depression that has not responded to one prior course of antidepressant therapy. But as we'll talk about later, that doesn't really translate out to how it's done in clinical practice because of insurance guidelines and restrictions. In 2013, it was also approved for migraines with aura. And I include a little picture here of the migraine devices. They're actually handheld and very portable. And it's nothing like that device setup that I showed you earlier for depression. It was also approved for OCD, obsessive compulsive disorder, later on, a couple years after. And the setup is more similar to what you saw earlier with the big machine and also the dentist-like chair. Finally, in the last 3 years now, it's also been approved for short-term smoking cessation and also comorbid anxiety symptoms in MDD. Just keep in mind that you're not really going to be seeing that much because this was only approved for one specific device manufacturer with a very specific guideline on how they're doing the TMS treatment that a lot of people just don't do or can't do. Finally, in 2020, I believe, NeuroStar, which is one of the major device manufacturers, was granted breakthrough status by the FDA to look into how TMS works in terms of for bipolar depression, for bipolar 1, as well as for bipolar 2. So we're going to be probably seeing the results of that, I would assume, in the next few years coming up. So if there's going to be any kind of major clinical indication that TMS might be granted, it may be for bipolar depression coming up. There have been a lot of decent studies now demonstrating the effect of TMS, and many of these have actually been sham controlled as well. Granted, the evidence is still not as solid as that for ECT. So after the pivotal 2007 study that resulted in the FDA approval for TMS, there were some mixed findings in regards to the significance of benefits from TMS versus sham TMS. But later studies, especially kind of in the recent 5 years, have been much more consistent in favoring TMS, particularly ones now on this new very high frequency theta burst stimulation protocol, which we do here. And of note, lesser degrees of treatment resistance may be associated with a better response to TMS, which is a similar pattern as most of our other treatments. TMS versus ECT, this is the question of the decade, I think. So right now, all we know is that TMS is either less effective or just as effective as ECT. The remission or response rates really vary depending on the study that you're looking at, the parameters they're using, what they're saying in terms of definition of response or remission. But generally speaking, we're looking at kind of between 46 and 64% of patients achieving response or remission ECT groups versus a wider range of anywhere between 16.7 to 55% in TMS groups in these comparative studies. TMS does have a huge boon for it, which is that it's an office-based procedure. It doesn't require any sedation, anesthesia, hospitalization, or any kind of recovery time whatsoever. In fact, we tell people when they get referred to us that, you can drive back from TMS, you can drive back to work and immediately do whatever you were going to do going about that entire day. You cannot do that with ECT. There are no known cognitive adverse effects also with TMS, which is a major concern that a lot of patients come to us with when they're thinking about ECT, for instance. However, ECT, like I mentioned, is still considered the best for some depression kind of syndromes. For instance, depression with psychotic features, depression with a presentation of acute suicidality, depression with associated catatonia. How about TMS versus esketamine? There's really no comparative head-to-head efficacy study, so I can't really tell you. As far as we think about it in terms of comparing the two, it's really the availability and also the insurance approval that are the key determinants for what you guide a patient towards. Esketamine, though, is approved uniquely for patients with major depressive disorder with acute suicidal thoughts or suicidal behaviors, which, as you'll see on a later slide, TMS is actually contraindicated for. So somebody comes in with depression and active suicidal ideations, we cannot do TMS on that patient. Esketamine is approved for that, though. It does require a lot of downtime. So in this sense, it's a little bit similar to ECT. To give you guys an idea, though, when you go in for esketamine, you go to a clinic, has to be REMS approved. The physician has to be also approved. The physician then monitors you after you get esketamine for about 2 hours at the minimum. You are told that you can't drive, operate machinery, or do anything where you have to be completely alert until really the next day. So in other words, you have to get somebody to drive you to and also from the treatment, just like with ECT. Esketamine, as you guys probably know, is also associated with sedation, dissociation, abuse, and misuse. So TMS, in terms of practical kind of clinical practice guidelines for depression, it's incorporated pretty much by major clinical organization as an accepted treatment option for patients who have failed to benefit from initial antidepressant medication treatment. The APA is a little bit vague about it. They did include it in the last guidelines released back in 2010 and just kind of lump summed it with everything else and just said, hey, if this doesn't work, you can try TMS and all these other things too. Interestingly enough, the Canadian Network Association actually put TMS above ECT unless somebody really wanted ECT, which is not the case with pretty much any other organization. So I just thought that was interesting there. As for TMS indications for major depressive disorder, note that I put parentheses, this is guided by insurance because a lot of this is really for them to kind of limit coverage for patients. It's a very expensive procedure. First things first, patient has to be adult, has to be diagnosed with severe major depressive disorder as documented by specific rating scales that we use in psychiatry. The most commonly noted ones that you might kind of see us write is a PHQ-9. That's a patient health questionnaire. It has 9 questions. You can give it to patients and they can fill out themselves in the office before treatment. So it's a very easy to access way of kind of providing an objective measure of depression symptoms. So if you don't have the documentation, for instance, and you just write the patient has a diagnosis of depression or major depressive disorder, that's not enough. The patient also has to have failed anywhere between 2 to 4 med trials, depending on what insurance companies you're looking at and how prohibitive the insurance companies is. The medication trials have to be of adequate dose and duration. Some insurances, they require that the medications have to be from 2 different medication classes, like we talked about earlier. And some of them also require that the patient has had 1 to 2 augmentation trials. So for instance, you have them on an SSRI, they've tried some other medications, but they also have to have an augmentation trial, say with bupropion, Wellbutrin, or maybe Abilify aripiprazole. The other exception to this is that you can also apply for TMS if the patient has evidence of demonstrated and documented adverse side effects to multiple medications back to back. Finally, the patient also needs a failed trial of evidence-based psychotherapy, and specifically they're looking for individual psychotherapy like CBT, for instance, cognitive behavioral therapy. So it's a lot to kind of ask for a patient, especially when you think about how difficult it is to access therapists nowadays. As for contraindications, and I think I saw somebody ask this in the chat, so this would be relevant. The main contraindication that panned out from all the research is the first one, which is that you cannot have magnetic sensitive metals or devices near the head. And the guideline there is usually 30 centimeters. So this includes a lot of stuff, right? So think about anything in the brain. So aneurysm coils, aneurysm clips, cochlear implants, staples, stents, implantable cardioverter defibrillators and pacemakers, and of course, deep brain stimulators and vagal nerve stimulators. These last 2, by the way, you're not supposed to know. They're kind of much more invasive neuromodulation therapies that we use for depression. I will say that there is a caveat though, because somebody asked about the pacemakers, because there have been case reports of people who do get TMS with pacemakers. And the key for this is that we have to consult the cardiologist. They have to be like very closely involved. They have to actually check the pacemaker brand and check with the manufacturer to make sure that it's okay with the TMS. So a lot of caveats there. History of seizures or risk factors for seizures. The only exception being that if you had like a transient seizure, like as an infant, like a febrile seizure, for instance, as an infant, that is usually still okay. Patients cannot have active suicidal ideations. They cannot have psychotic symptoms. They cannot have catatonia. They can't have active substance use disorders. They can't be pregnant or nursing, although again, there have been studies showing that it's probably safe in pregnancy. They also cannot have a lot of major neurological conditions that ranges anywhere from strokes all the way to CNS-based tumors. So what does the treatment course look like? First, there's a pre-treatment evaluation by the treating psychiatrist. Then in this case, we'll determine, does the patient need any kind of medication adjustments? Are there any medications that put them maybe at higher risk for seizures? Are there maybe medications that might kind of lower the ability for TMS to work effectively, like benzodiazepines, for instance? And if there are medication adjustments, we don't make those. I will basically have the primary treating psychiatrist that's already taking care of the patient make those adjustments before they come to me for TMS treatment. In the first session, we do what is called cortical mapping. So a little orientation again. Here is your M1, your primary motor cortex, aka the precentral gyrus. It is responsible for planning and executing voluntary movements, of course. And here is the cortical homunculus. And just take a note right here, the thumb is right over here. So the reason I mention that is that we actually look for the motor threshold on the first treatment session, the first cortical mapping session, I should say, which is just the lowest level of stimulation that's capable of causing a twitch in the contralateral thumb. So when we're applying the stimulation to the left side of the brain, obviously we're going to be affecting the right thumb in this case, the abductor pollicis brevis muscle specifically. Then we approximate the location of the left DLPFC, that dorsolateral prefrontal cortex that we're trying to aim for from this thumb location. And we conduct 30 treatment sessions from there on. This usually runs 5 days a week on weekdays for about 6 weeks. And taper sessions is kind of on an as needed basis. It's not really clear because there's no guidelines or guidance on this formally. It could look something variable though, like 6 sessions over the course of 3 weeks, for instance. TMS is extremely well tolerated, and this is what I think it has going for it, especially when you compare it to ECT and compare it to esketamine, or even comparing antidepressants. In fact, if we look back on a lot of the medication trials previously that showed the benefit of TMS, there were very, very low rates of dropouts, like as low as 5%. That's unheard of for our antidepressant kind of trials and medication-based trials. Later studies have also kind of shown that, again, it's well tolerated. The most common side effects reported being headache. With the headache part, only really 5% of patients who get treated with TMS report this general head discomfort in the first couple of sessions. It mostly goes away after they get used to the treatment, though. A very small minority of patients could experience a tension headache. This, of course, usually also goes away too within about a couple minutes to up to about 2 hours or so from what we see from the research. The most uncommon, but also most serious side effect is seizures. The risk being about 1 in 10,000 to 1 in 30,000 treatments. So considering that each patient's getting about 30 sessions total, the total estimated rate is 0.1%. That's 1 in 1,000. To put this in perspective, our commonly prescribed medication that we talked about earlier, bupropion, Wellbutrin, is estimated to cause seizures at a rate of 0.4%, which is 4 in 1,000. So in other words, some of our really commonly used medications have more risk to induce seizures than TMS. So this should not be a reason, in other words, to hold you back from having the patient, look into TMS and get TMS treatment. Here is a slide about other neuromodulation therapies. We talked about ECT a little bit, we talked about TMS, the general gist here, of course, is that ECT and TMS, they're both FDA approved. ECT has been proven safe and efficacious. It's limited by this risk of memory impairment that scares a lot of patients. It's also limited by psychosocial disruption to the patient's daily life. They have to really take off a day, take off sometimes weeks just to get ECT treatment. Limited by sometimes access and definitely a lot of stigma given what's been shown on TV and popularized in movies about how about how ECT previously looked like. TMS is also FDA approved. It has overall still less evidence base than ECT. The efficacy, as far as we know right now, is either similar to or less than ECT. It's generally pretty well tolerated. VNS here, and kind of, these last 4 right here, you're probably not really going to need to memorize, you probably don't really know about, but I'll give you a general idea of them in case they do come back in resurgence of popularity. So VNS is vagal nerve stimulation. It is actually FDA approved, and it's the only other one that we haven't talked about that is FDA approved for treatment-resistant depression. It is also approved actually for treatment-resistant seizure disorders. It requires a surgical implantation of this device that's about the size of an Oreo cookie. As you can imagine, there's a lot of potential for messy technical problems. So for instance, battery malfunctions and a lot of side effects associated with messing with the vagus nerve. So specifically cough, hoarseness, sore throat, headaches, all of which have, I think, really resulted in very limited clinical use of this treatment, despite it being FDA approved. It does come with a pulse generator, just like a pacemaker, and it sends electrical pulses to the left vagus nerve in the neck and which then transmits these pulses to areas of the brain that we think are hypothesized to help with regulation of mood symptoms and depression. It's not reimbursed, so the whole surgery is at least $20,000 or so. It's a lot of money to foot. It's also limited by really unclear evidence, although there are still trials going on with VNS registries nowadays. Also limited by the technical problems and side effects I mentioned earlier. So next one, MST, magnetic seizure therapy. This is mostly investigational treatment. It's kind of like a hybrid, if you will, of TMS and ECT. Essentially, it uses magnetic coils, just like TMS, and it induces one seizure per treatment, just like with ECT. It has very similar anesthesia requirements and treatment frequency as ECT, so it's not really clearly any beneficial in terms of comparing to ECT, and certainly not beneficial over TMS, given how difficult it is to have to deal with the downtime and then also have a seizure on top of that too during treatment. Next one, DBS, deep brain stimulation. This is another neurosurgical procedure where an electrode gets implanted extremely deeply into the brain. It gets connected then to subcutaneous generators on the scalp, and the stimulator can be adjusted. Right now, it's not FDA approved for depression. It's only FDA approved for Parkinson's disease and essential tremor. And then TDCS, transcranial direct current stimulation. It's another investigational treatment. And the focus of some of my research before, it basically uses a direct weak current to stimulate the brain. Overall, no really benefit in sham control studies, so I wouldn't put too much faith or effort into that. So let's go back to our clinical case from the beginning. So you have this patient, and now thinking about the patient's case a little bit, you can kind of parse out that, okay, he's been on 3 antidepressants, right? Fluoxetine, escitalopram, you realize these are 2 SSRIs. He's also been on venlafaxine, Effexor, that's an SNRI. So 3 different medications from 2 different medication classes in his current depression episode. He says he doesn't want ECT, so what are your treatment options, right? You can switch him to something maybe he hasn't tried, so think about a different class. So switching him, and this is not for you guys to do, this is for us to do when you refer him over to our clinic. We'll switch him over to a TCA, tricyclic antidepressant, or MAOI, monoamine oxidase inhibitor. We might also augment him with something else like atypical antipsychotics, lithium, maybe T3. We can refer him over to TMS treatment. We can also maybe refer him over to S-ketamine treatment if that's available. And here are some general conclusions pulled from the presentation. So some summary points. Only a minority of patients really achieve remission of depression symptoms with their first antidepressant trial. Treatment strategies for depression include medications, neuromodulation treatments like ECT and TMS, and therapy modalities. TMS is a non-invasive form of brain stimulation based on principles of electromagnetic induction of current. TMS changes the propensity of cortical neurons to produce an action potential. It's a safe and effective treatment for major depressive disorder, not benefited by medication trials and also not benefited by therapy. It's really not a replacement for ECT in the treatment of major depression, but it's definitely less invasive and does not require anesthesia. Here are a lot of references. And thank you, by the way, Dr. Epstein, for looking over these slides and making sure they were appropriate for the audience. And thank you to everybody for your attention and for being here.